Hi, everybody. Welcome. My name is Gabi Conicor, and I'm the executive director and co-founder of Decoding Developmental Epilepsies, which houses this incredible project, the Inchstone Project. And you'll see a bunch of our PIs here on the screen with us, and you'll be hearing from all of them today. We're missing Anberg today, which is, of course, a loss, but we have plenty of amazing stuff to share with you, and we're really thrilled to have an opportunity to be in front of you all again. Our goal is always to be working with, on behalf of, and really in partnership with the community. So it's really important for us not to just have all of the incredible families who have given their time to participate in this work, but also families who are interested in this, want to know more, who this impacts in the long run, be a part of listening in and giving us feedback on the work that we're doing. And a lot of that comes in the form of patient advocacy leaders who have been incredible partners in this work, and we're really grateful for all that they have done. And so you'll hear a bit more about that today. I'm going to go quick because we got a lot of cool stuff to show you, and you don't want to listen to me for the most part. Today, what we're going to do, a rough agenda. We want to tell you about what we've accomplished so far, so you have a sense of what we've been working on and the groundwork that we've built to move this work forward. What we're learning, so you're going to hear from each of our principal investigators about the work that they have been honing in on. This has been an incredibly collaborative project, and our team meets every week and talks and shares and learns, and it's really a beautiful process that we have together. But there are people who are leading on certain elements, and we want you to hear from them. Um, and then we want to tell you a little bit about where we're heading, and what's in store and how you can get involved as both individuals and patient advocacy leaders and clinicians and industry. There's room for everyone at the table here. So I'm going to quickly run through some of the exciting things that we've accomplished. So I think many of you know what one of the earliest things that we decided to do was to do a pilot and see how well are the tools that currently exist working in people who are pretty profoundly impacted by rare disorders like SCN2A. And of course, Leah and her team were gracious enough to, like, I think we had like a month's notice. We're like, hey, can we come to your conference and do a bunch of assessments on kids? And she's like, sure. So they've been amazing partners. And from it have come a number of publications that are really looking to build a foundation for the work that we're doing here and justifying why we really believe that this work is necessary to ensure that there are clinical outcome assessments that can measure progress in those who are profoundly impacted by disease. And I think a lot of you who are on the call today, who will be watching this, know that there are gaps in the tools that are being used in clinical trials and, frankly, in clinical care. We have several clinicians with us today who could speak to that as well, who are on our team. But there's really a need here to have better tools that can actually look at not just the inchstones of progress that people make in the positive direction, but if there's regression as too. We know that's a really common feature in DEEs and other neurodegenerative disorders. So what we've also really been excited about is this DEE Parent Speak survey that we did, which was over 260 families across a wide range of disorders who all took the same assessments in this on this online portal that we hosted on Clearance, which is a great tool hosted by Jerry Nesbitt. And what we did is it was an extensive survey, so a lot of data. And these, you see, this is the overall data. All of this is on our website if you're looking to get a closer look, because I know I don't think anybody's eyes are good enough to be able to see these, but for the highest groups that participated, groups that had the highest participation, we made these dashboards for them. Our program manager Kelly did this. She's amazing. And we were able to really give summaries of the kind of things we were seeing in each of these disorders and how they were very similar in a lot of ways, and maybe some and ways that they're struggling with a lot of the same things. Um, and Another thing that we've been really working very hard to do is have open communication with the community about the work we're doing. We have one of these sessions at least once a year. We have open meetings. We give presentations. Over the last several years, I think it's more than this now, probably closer to 85 presentations that we've given at conferences, at meetings. Some of our researchers are going to different family meetings with different foundations to talk about the work and the tools that we're working through, and even testing some of these tools. So we're really looking to be present in a lot of different spaces to help share what's happening here. And some of these are the way that we're also doing this is we're really trying to advance this conversation about not only do we need tools that work better to actually capture the progress of those who are, severely impacted by diseases, but also that there's a lot of urgency to get better treatments to more disorders, more families sooner rather than later. And, Jayetta led the authorship of this paper, which is really fantastic about how a patient advocacy-led organization can really work to build a collaborative research network that's doing all this incredible work. And Ann Berg had this really fantastic paper that looked at the patient-focused drug development out of the FDA guidances and providing very, very thorough feedback on how we need to do better at making sure this population is not left behind. Lastly, I'll just mention that in November, we were thrilled. We got it in under the wire before tides shifted in terms of what federal agencies are able to do. But we had a fantastic patient listening session with the FDA, really honed in on this sub-community of developmental and epileptic encephalopathies, which, if you're not familiar with it, it's really this subpopulation of people who have often very difficult to treat epilepsy, along with there's some EEG irregularities and either developmental stalling or regression, or in the case of my son, is like almost no development. It can either be that there isn't development, a regression, or a stalling. So this was an incredible turnout from the FDA, great feedback from them about the work that's happening here. We have plans to continue the conversation with the FDA whenever they are open again for external communications and discussions, and also with other regulatory agencies to make sure that we're in line with the work. Our work is in line with what they need in clinical trials, as well as, we'd also work very closely with our industry advisory panel, which is a number of different a number of different pharmaceutical companies who really see the value in this work and understand that it's going to be really important for their clinical trials that are looking at, disease-modifying therapies, that they are going to be able to measure change in a broad spectrum of heterogeneous disorders. So with that, I'm going to pass it. Oops, looks like that got messed up. I'm going to pass this over to Mary to tell us about our progress with the DP4.
Yeah, great introduction as always. I'm excited to be here and share the results from what we're learning about the DP4, or the developmental profile, which is a rating, a parent-reported measure of development. Since I'm going first, the next few talks are going to really be about the results from the DEE Parent Speak survey that Gabi mentioned. And I think many of you on the call are probably familiar with this, but just to orient us, it was a survey that we completed, I guess, in 2023 now, where we had over 260 parents and caregivers of individuals with severe to profound functional impairment complete several rating forms or measures about development, quality of life, vision. It's a really rich, large sample that gives us a lot of information about people who are functioning in this range. So thank you to all of you who are on the call that filled out the form. We're still analyzing the data and really learning a lot from it. So the DP4, or the developmental profile, was one of the forms forms that we had parents or caregivers fill out. As I mentioned, it's a measure of development, and it measures these 5 areas of functioning. So physical development, adaptive behavior, social, emotional, cognitive, and communication development. There's about 30 to 40 items on each scale, and then caregivers answer yes or no for each item. And the original instructions encourage or require that families fill out all of the items, but given that we were really trying to focus in on this sample of kids who have severe to profound impairment, we really just asked parents to start at the beginning, and then once they circled 10 no's in a row, they could stop. So the items start out easier, and then as you go through each scale, they represent increasing levels of advanced development. So once you circle 10 no's in a row, we thought that the items after that would be more challenging. And one of the things that we're really sensitive to is trying to make sure that families aren't harmed when they're filling out our forms, that there's no additional distress that comes along with the forms. And we know that circling no over and over again can be really distressing. So that was a change that we made to really focus in and make sure that we're meeting the kids that we're trying to learn about. This form is used quite commonly in clinical practice. I've been using it for over 10 years. It's not, I think, as well used in clinical trials or in other areas of practice. So we really wanted to learn more about how this tool worked. So there's a lot of analysis looking at that. So if you go to the next slide. So this is a busy slide. When you score a rating form, there's lots of different numbers that you can get, and each of those scores tell you something different, and so they're all important. What we often get from a tool like this is what's called a norm reference score, where we're comparing kids to what typically developing children their age do. And that's normally when you see like 100 is average. But oftentimes for our kids who are in the severe to profound range, they're all getting scores at the floor, which is just the lowest score that's available or provided by the test, which really doesn't tell us anything. We know that their kids who have different levels of ability can get the same score. And when you start out low, it's really hard to measure any change. So we often look at raw scores, which are just the total number of items that a kid got correct or answered on the scale. And what's really important or really helpful are age equivalencies. So this gives us a little bit of information about the functioning level that's more sensitive rather than just a score that compares a child to other children for their age. So you can see, we really focused in, if you look at the middle column, that's the age equivalency column. We really wanted to focus in on kids who are functioning in this severe to profound range of impairment. So even though I think the overall age or the average age of individuals with DEE in the sample was 10, their average age equivalency on all of the scales was under 10 months. So we're really seeing a very profoundly impacted sample. The other cool thing or interesting thing or promising thing that I want to point out is that the median or the middle score on all of the scales for the raw score over to the left, on the left side of the column, that wasn't a 0. So there are people who we're measuring skills that kids, even in this profoundly impacted sample, have. If you go to the next slide. And I think, as I mentioned, we really started out looking at kids with DEEs or developmental developmental and epileptic encephalopathy. Sorry about that. But when we really focused on the functioning level, we really ended up with a sample with some kids who didn't have epilepsy, who had not had a seizure. So I thought it was interesting and wanted to point out and gives us some data about the impact of epilepsy on development. You can see that the kids who don't have epilepsy, their age equivalencies, and again, those are in months, are higher for all of the scales than kids who do have epilepsy. If you go to the next slide. Okay, so then we really want to look at the validity of the scale. So validity is, when you're looking at a scale or a test, you want to know, does the test measure what you're intending it to? Is it actually measuring the thing that you say it's measuring? In this case, development. So we saw some evidence for validity on the DP4 in this sample. So as you might expect, older children usually have higher developmental skills. So as you get older, your development increases. And so what we saw, even in our sample, is that older children receive significantly higher DP4 scores. So kids in this sample, as they're getting older, are showing more developmental skills. And then if you all remember, one of the things that we asked within the survey is information about a kid's functioning level in these four main areas of functioning. So their communication, their ability to walk, their ability to eat by mouth, and then their use of their hands, their functional use of their hands. And we asked parents to rate their child's level of ability in each of those areas. And what we looked at then was the kids who had the most profound level impairment in each of those areas. And then we compared those who had a different number of profoundly impaired domains to their DP4 scores. So as you might expect, kids who had a larger number of profound impairments in those four main areas had lower DP4 scores. So as you would expect, kids who had greater or more profound impairments and more of those profound impairments had lower developmental scores on the DP4. So these two things really give us some information about the validity of the DP4 and that it's actually measuring what we want it to be measuring in this sample, which is development. If you go to the next slide. And these next two slides are just visual representations of those things that I just talked about for those of you who are more visual learners. So you can see age equivalencies on the y-axis, on the vertical axis, and then along the x-axis or the bottom of the graph, those are the 5 scales of the DP4. And then the different colors represent different age groups. So 1 to 4 years, 5 to 9 years, 10 to 14 years, and then 15 and up. So you can see for each scale, adaptive behavior, social emotional, and on, that each of the bars get a little bit bigger as the kids get older. So older kids are getting higher scores or higher age equivalencies on each of the scales. If you go to the next graph. Here again, you can see age equivalencies on the left, on the vertical axis. Along the bottom, the numbers 0, 1, 2, 3, 4, those correspond to the number of domains that were in the profoundly impaired range. So you can see, again, for all of the scales, kids who have 0 profoundly impaired domains have higher age equivalencies. And as the number of profoundly impaired domains increases from 0 to 1 to 2 to 3 to 4, the age equivalencies are lower. And then this is something that I think we're really excited about. So we looked at a rash analysis with the DP4 in this sample of kids who are profoundly impacted. And what the rash analysis tells us really is, does the difficulty of items, are we really looking at a difficulty of items to match up with the ability level of kids in the sample? So the question is, do kids with higher ability level get yes answers for the more difficult items or the items that measure more advanced development? So it really is a way to analyze a scale that measures a certain ability, like development, which the DP4 is measuring. So when we're measuring development or a skill or a knowledge, usually the scales are ordered with easier items at the beginning, and then as you go through the scale, the items get harder or they represent more advanced levels of development. So on a good scale, if it's working well, the items increase in difficulty in a way that matches the real world. So 2 is harder than 1, and 3 is more advanced than 2, and so on. So we would expect that kids who are more advanced developmentally or who are older would answer the harder items or get a yes on the harder items. And the kids with lower developmental ages or who are younger would not get those answers correct. They're not able to complete the task. So rash analysis looks not just at the number of items that you answer correctly, but also which ones you answer correctly. So if a kid with higher ability does not get one of the earlier or easier items correct, then that tells us that something is off about our items or the questions that we're asking. So the authors who designed the DP4 did a rash analysis, but the sample really didn't include people who are functioning in the severe to profound range. So those are the kids that we're really focusing on. So we wanted to see how well it worked in that population. And overall, the answer is pretty well. So the items on the scale increase in difficulty in a way that matches what we would expect. So kids of higher developmental ability are more likely to have a yes response for the more advanced items. And kids with lower ability do not get yeses for those harder items. There were some items that didn't, it's not perfect. There were some items that didn't fit well. For example, maybe a kid with a lower level of ability received a yes answer on a more advanced developmental skill. Some of the scales have big gaps in between items, so there's a big jump from one item to the next item. So we're really not measuring kids well who fall in between those two items. And although there were many items that did work well overall, and even some kids who are very significantly impacted were getting yeses to some of the earlier items, there were many items that were too hard for the kids in our group, where the items were above the ability level of most of the kids in the sample. And I think some of the other information that we learned about the DP4, which I think is really the most fascinating and really learning from that, is the parents' thoughts about the measure. So I'm not going to read all of this, but I think there are some main themes that came out and that were reported to us by parents about how they felt the DP4 captured their kids' skills. And I don't think any of these are going to be new to any of you. There are things we've been talking about that you've experienced when you filled out forms. You know, some of the things that I think are most important is that the yes/no format was hard because sometimes kids do it and sometimes kids don't. And it can depend on the day or whether they had a seizure or who they're with, right? And the DP4 doesn't really allow for that inconsistency. Sometimes the skills jumped, the items jumped really too far, too fast in terms of development and difficulty. Parents were reporting sometimes that it was really hard to circle the no's. At the same time, I think we had many parents report that they were able to answer yes more often than other rating forms that they had filled out. So pretty excited about that. If you go to the next slide. I think a big thing for our kids is that they may demonstrate a skill with a different method, maybe a communication device or an adapted spoon, right? And the DP4 doesn't really allow for the ability to demonstrate a skill in a different way. We're asking items that may not be always appropriate for the chronological age of the individual. And I love this one. There's the items that I think are really important to families that demonstrate a certain level of development or communication or understanding that aren't asked about on the DP4. Humor being one of those. So if your child laughs at the right moment when other people are talking in response to something that's funny, or does something silly like to tease someone, that's not really on the DP4 and represents a certain level of understanding or development. So in summary, we think the DP4 has potential. It's working quite well in a lot of ways. It's measuring what we think it's measuring. It's capturing kids of different levels of different ability. The items are right for the level of ability if we're looking at that Rosh analysis. But as I said, it's not perfect. It does have some things that don't fit this population as well as we would like. One of the things that we're really excited about is a short form for individuals who are in the severe to profound range of impairment, and exploring which are the items that work the best for those kids, and maybe having a short form or a subset of items that we really use for kids who are in that functioning range. And I think what's really exciting is really understanding parents or caregivers' perspectives on the form, and what we can use from those focus groups as we're developing or modifying or thinking about new forms to measure development.
Thanks so much, Mary. It's really exciting progress. And what I realized I probably should have asked people to do is introduce yourselves when you start, and where you are and what you're doing. So maybe you can do that after the fact now.
Yeah, Mary Wojnarowski. I'm a clinical psychologist, and I'm at Nationwide Children's Hospital in Columbus, Ohio.
Thanks, Mary. And Mary's really been spearheading this work, which is super exciting. So thank you so much, Mary. All right, we're going to move on to Natasha, what we're learning on the awareness front.
Yes. So, hi everyone. I'm Natasha Ludwig. I'm a pediatric neuropsychologist at Kennedy Krieger in Baltimore, Maryland. And I see a lot of patients clinically who have DEEs, and particularly patients who are functioning in the more severe to profound range of impairment, and also other children, without DEEs who are functioning in this range as well. And a big part of my job is to work closely with medical teams to help medical teams understand whether a particular treatment might be working, or may not be working, or may be harming from a developmental standpoint. And so a lot of times when I see families, I ask them, how is your child doing, right? What does a good day look like for your child? And a lot of times when I'm working with this population, I hear things like, oh, they're, smiling more, they're more engaged, they're more alert, they're more aware, they're more responsive. And so I think that this is a really kind of meaningful construct or thing or function for this group. And so actually here, this is a cute little smiley graphic, but actually this is a word cloud that's actually data driven. And so when we asked parents and caregivers, what does a good day look like for your child in the caregiver survey, this is actually what their responses look like. So we saw a lot of smiling, laughing, but also alertness, engagement. And so you can click to advance. Yep. And you can click one more. Sorry, I didn't realize it was animated. So these concepts I think are really meaningful to these particular patients, right? And so it makes sense that, we might want to have a measure that can tap into these things, right? And so when we think about learning and development, certainly, being able to perceive our world is really foundational. So sensory functioning, but then being awake and alert and responsive to our environment is really important, right? To then maintain attention, and can really set us up for learning and development to occur. Of course, this is a very simplistic version of what learning and development looks like. There are many other factors, right? But I think that this just emphasizes the importance of this really basic cognitive function of responsivity. So certainly targeting alertness, awareness, and responsiveness is likely meaningful for these patients. And so you can click next slide. And so thinking about what measures do we have in our toolkit that target this? And typically, as a pediatric neuropsychologist, there's really not a lot of tools that we have that really tap into these skills. And so we had to look to, other disciplines. And so we actually borrowed a tool from the rehabilitation literature, which is a clinician administered responsiveness scale that really gets at these elements of, alertness, awareness, and responsivity to the environment. And so just as a reminder, when we did our pilot study with the 10 individuals with SCN2A, we did administer this assessment. It's a performance-based assessment. And we actually found that there were really no absolute floor effects or absolute ceiling effects, which means that participants were scoring really kind of in the middle of the measure, and there was some good variability there, which is a really good features of outcome measures. There was some room for improvement though. So on the individual subscales of this measure, there were some ceiling and floor effects. And there's also aspects of, we know are common in this population, like cortical vision impairment, that weren't really accommodated, on this measure. So certainly some room for improvement. I'm not going to, just for the sake of time, I won't go into the picture here, but if you click the next slide, this is actually directly from this publication that came out the end of last year. So you can go ahead and take a look if you'd like some more information on that graph and those findings. Next slide. So because we found such promise with the performance-based measure of responsivity, we decided to adapt a caregiver-reported responsivity measure that maps directly onto that performance-based measure of responsivity. And so we basically we gave that measure, we administered it in our to the sample of 10 individuals with SCN2A, but also in our parent speak survey. And so now we have a lot of amazing data to look at. But I just wanted to give you guys a little bit of some concrete examples of what the measure exactly gets at, right? So there's different domains, so like auditory, visual, motor, vocal, and some of the questions, I just picked a few that are a part of these different domains on this questionnaire. So does your relative move their head or eyes towards the location of sound? Is your relative able to recognize two objects that are presented to them? Is your relative able to follow with their eyes? In the motor domain, does your relative move their hand to grasp an object and hold it? From the vocal domain, does your relative produce sounds? And then communication, does your child cry or smile? And arousal, does your relative usually keep their eyes open independently during school or therapy? So just to give you some idea about the kinds of questions that are asked. Of course, there's many more questions, but these are just some examples for you. So what we found is that there's actually pretty strong relationship between that clinician administered or the performance-based responsivity measure and the caregiver reported responsiveness measure. So this is a good thing. This is showing us that there's some kind of continuity between these two measures, and that potentially, this is very early data, of course, but potentially this is telling us that we could use the parent report version in certain contexts, and it might get at, a similar ability level if we were to administer it directly to the patient. Next slide. All right, so this is a complicated visual, and I think you may have seen this before, but I just wanted to remind you all that when we looked at the caregiver-reported responsivity scale, we actually did find that that the scores do correspond with level of impairment on those cardinal functional skills that Mary described earlier. So as you have more severe levels of functional impairment in communication, eating, mobility, those sorts of things, the scores on the caregiver responsivity scale are going down, which lends some preliminary evidence that this, has promise as a measure and is measuring what we expect it to. Next slide. Okay, so this is another kind of complicated image, but what I wanted to highlight here is along the x-axis, these are the DP4 cognition raw score points, increasing from left to right. And then on the y-axis is the caregiver responsivity score. Of course, as score goes up, that represents more responsivity. And what you'll see here is that when I look at the children who are functioning at or below around a 12-month age equivalent on the developmental profile for cognition scale, we're seeing lots of variability in their responsivity. More variability than the DP4 would give us. And so this is telling us that these kids, while the DP4 might show that they look similar, the responsivity scale is showing some range and variability in an aspect of cognition that isn't really being assessed by the DP4. So I think that what this tells us is that the measure may be most helpful for those who are the most severely impaired, which is exactly our mission here and what we're trying to do. And so I was really excited by this finding. And again, these are findings from the Parent Speak survey. Next slide. And I think this is my last slide. So just wanted to summarize some of our ongoing work. So as I mentioned earlier, even with the caregiver reported scale, there's going to need to be some adaptations, right? So we do have some limited variability in scores on some of the scale level. And also there needs to be accommodations for things like cortical vision impairment. We know that. And so the first step in modifying these measures is to do some qualitative work, which is really what we've been focused on. And so we've done some focus groups, as Mary has done with the DP4. We've done some focus groups asking families to give us their feedback around the caregiver responsiveness scale. And so we have started to look at that, and we're learning a whole lot. And certainly caregivers have communicated that, the scale is good, but there's room for improvement. Additionally, we are developing a conceptual model, which is basically like a concept map of what this idea or this construct of responsivity really is. Because I can tell you as a clinician, when I ask families, how their child's doing, they may say, oh, my child is more or less responsive. I typically have to say, well, what does that mean, right? And the definition is a little bit different to everybody. And so we need to have a good, solid understanding of really what we mean by this idea of responsivity. And so we had some questions on our survey about, what does more responsivity look like? What does less responsivity look like? And what factors impact your child's responsivity? And that data is incredibly rich. We had 163 caregivers give us some really nice data from the survey, responding to these questions. And we have learned a whole lot. We're still in the middle of analysis on that. So, but I can tell you, we're learning that this concept of responsivity is so broad. So there's physiological aspects of functioning, there's movement aspects, attention, engagement, and not only just attention engagement, but social engagement as well. Communication, affection, and humor and silliness, like Mary mentioned. These are ways that caregivers evaluate whether their child is more or less responsive, and how they conceptualize responsivity for their child. And so this has been really important. We also learned a little bit about some of those factors that caregivers believe are impacting their child's level of responsivity. And so some examples that have come up are both internal and external. So from an internal standpoint, health status, right? So pain, seizures, medications, and then from an environmental standpoint, who's around them? Is it a familiar adult? Is it a unfamiliar adult? And then just genuine interest in the activity at hand, right? And so this has been a really wonderful project. We're learning so much with these data, and we're just so grateful for the richness of information that you all have shared with us on this topic. It's really, really moving this project forward, and we're really excited because it's really going to translate into the next phase, which will be that adaptations of these tools. So thank you so much.
Thanks, Natasha. That's fantastic. Yeah. And then these are tools you'll use more in your clinical care too, right? We're developing these for clinical trials so that when there are drug trials or, different things in trial to potentially help, all different kinds, that they're really going to be able to see whether this treatment, maybe it's not going to be the best treatment for seizures, but maybe it really helps with responsiveness and cognition and all of these other things that are really important to quality of life for our families. Okay, meaningful change. I get to welcome Jenny Downs to join us.
Thank you, Gabby. Thank you very much. It's awesome to follow you, Mary, and to follow you, Natasha. And so now we're coming to a topic which is generic to all of the domains that we're interested to measure. And we're really wanting to further our understanding of what meaningful change is across a range of domains. And this did follow on from a small interview study we did with 10 families who have a child or young adult with SCN2A, DEE, and those were extraordinary interviews. Those parents were wonderful and shared very, very important information so that we started to get an understanding of meaningful change. And meaningful change is a really critical concept. It's critical to all of us when we're making decisions, yes or no, do I do X or Y, or will I go there, or how will I approach this problem? We're weighing up the balances. What are the positives? What are the negatives? What are the risks? What are the likely benefits? It imbues all of us in our lives. But from the point of view of measurement, it is important that measures are reliable. They'll tell us the same information consistently, if that is the truth. They will be valid, and both Mary and Natasha showed evidence of validity. Tests that are telling us if the measure is telling us what we think it should be telling us. It's telling us it's reporting on the right concept, and it's likely to be close to a right answer. And then there's other aspects we need to understand that measures change if the child or the young or the adult changes. So that's responsiveness. But we also need to be able to interpret what those changes are. And they might be small, they might be large. We need to be able to give some sort of evaluation of what that change is. And it's for that reason that we're wanting to hear from parents what meaningful change is, because then we can have a new lens on interpreting what the changes actually are. So this comes to our DEE Parent Speak survey. 267 parents gave us information on their priorities for their child, what they would like to see improvement in. And we asked parents for their three most important domains, their top three priorities. We asked them to tell us what would the smallest improvement be that would be important and why. So we asked two questions. And so they said, this is my priority domain. My child does this, and then this is what I would like it to change to, and then said why. So for this sort of analysis, we focused on communication, expressive and receptive communication, gross motor, fine motor, and the eating domains. Because that maps to our expertise as a group. We're particularly have expertise in the developmental domains, and it really was it was a group of the most high priority domains across the set that we had for parents to choose from. So it makes sense that we focus on those domains. And in that text data, it's different to what Mary and Natasha described. This is text. So we used qualitative methods to look for patterns in those words. And from doing that, we were able to examine what those codes were, distill it down to codes that told us the content of the text. And then we could see how did those codes differ by different levels of impairment for the child. So for those functional domains, we had 493 descriptions. And with our analysis, we resolved that information into 89 meaningful codes across communication, gross motor, fine motor, and the eating domains. And you can just see a quick table there to see how they split across the domains. Next slide, please. So this is an example of the sorts of codes we had for expressive communication. And expressive communication was the most frequently endorsed priority number one. And so for those codes, there were 19 codes for expressive communication. Many of them described demonstrating preference. Many described expressing emotions. Only a couple described social connections. That doesn't mean it's less important, but we had codes there. And then the other codes were about how the child communicated, using words, using AAC, and a range of non-verbal communication methods. And that really, really was exciting to see the very wide range of modes that parents were wanting to see their child build their skills in. And really, we use nonverbal communication as much as we use our other forms of communication to communicate a language. The most common code, go back just a second, sorry, Gabby. The most common code was the basic communication of needs, wants and likes. You can see 56 times that came up. Communicating yes or no was a very common code. Expressing pain, hurt, and discomfort was very, very common. And a very large number of parents wanted improved AAC skills. And also the consistency of the communication right down the bottom was also coded, emerged from 12 of parents, what parents described as their meaningful change. So we saw some patterns. Sorry, big, I hope you didn't hear that. We saw patterns within the set of codes for this particular domain. So next slide now. So then we looked at how those different codes mapped to whether a child had less or more difficulties with the domain. And interestingly, for example, I've got two examples here. For expressive communication, meaning and purpose, which was our most common code, expressing preferences, feelings, and pain across the levels of communication. It was the same, irrespective of whether a child was able to communicate back and forth with anybody, whether they could communicate back and forth with a known person, or whether communication that was back and forth was extremely difficult. It still mattered for all of those children. We did not expect that finding. So what we did find was that the codes for the mode for how the child was communicated depended on where the child's level of impairment was. And so that makes sense. The children with more difficulties with their communication, parents would be really pleased to see more nonverbal modes of communication and so forth. In contrast, for gross motor, there were codes for walking, standing, transfers, sitting, and head and trunk control. And they very much mapped to the level of difficulties that the child had with their gross motor skills. And that makes sense because gross motor is a concept that is very much an incremental progression of developmental complexity with each of the different skills, whereas communication is a much more diversely variable sort of concept. There's a lot of different modes that we use. There are a vast number of meaning and purposes for the communication, and it's not surprising that because it is so complex that there were actually similarities across the different children. So if we go to the next slide now, the next slide is asking a summary slide of the information, how we coded why the meaningful change was important. And the codes mapped to better mental health, physical health, more independence and safety, more social well-being, and personal growth and quality of life. And all of those themes we saw in the child, in relation to the child. For example, the child would be less frustrated. They would understand their pain, independence, and this is so they can do things on their own, but also concepts like more dignity during self-care activities. Safety was important, for example, to be able to say stop, or of course, less falls with gross motor improvements. Social well-being boiled down to more capacity and opportunity for social interactions, and personal growth was and quality of life was important also for the child to be heard and really for their world to be expanded because of a greater level of developmental capacity. And there are a lot of the codes also mapped to the family, knowing the child's needs and being able to give more targeted healthcare, easier to help them feed and dress, and also personal growth and quality of life was important to the family for the flow-on effects. So to know and understand the child and for the whole family to be able to engage in more activities. So what these two concepts tell us, the what and the why, they tell us two things. When we're looking at our measures, we need to make sure that our measures can actually capture those codes that are important to families. And we also need to think about how a set of measures for a particular trial or testing a clinical intervention needs not only the domain, but needs to be able to capture how that child is living and include measures that are broader, such as quality of life. So next slide, please. What we're doing is we have a manuscript. It's had a couple of back and forths, and it's nearly ready for submission. We think it's really important to talk with you, and we have been talking with other community members and stakeholders about these ideas. This is new in the world of DEEs, and so we really are taking a careful approach to working with opinions and viewpoints and what parents are telling us and working with that data. But what we're hoping we can do is potentially measure, develop a battery of meaningful change questions for DEE conditions. But that really depends on our further analysis, our further discussions, particularly with you, people like you, to actually help us, tell us what you want us to do with this information. So thank you.
Thank you so much, Jenny. And now on to Becky.
So we, you heard everybody so eloquently talk about our research and what we're doing and how we're moving that forward. And one of the things that we consider is CVI. How can we make sure that the things that we're measuring are actual true measurements of our children's abilities, because they have access to it visually, right? If they can't access the things that we're showing them, how can we really measure what they know? We know that CVI can impact neurological development and compromise, the validity of the measured outcomes. And so we have to make sure that when we're presenting materials to our students, to our children, to the people that we're assessing, that we are doing it in a way that makes sense to them, that they have visual access to, and that they can show us what they know using their vision. We ask our kiddos with language delays or language deprivation to use their eyes to show us what they know. But if the things aren't meaningful to them, if they can't visually interpret the target, then we're not measuring what they know. We know that CVI is not an ocular condition. It's not something that's wrong with our eyes. It's an impairment that occurs inside of our brain, the parts of our brain that access visual information and make sense of that. CVI, we really must, especially for our students who have this significant impairment, we must ensure, I'm going to backtrack that for a second. It is the leading cause of visual impairment, especially in our kiddos with severe and disabilities. And so when there is trauma to the brain, there is a very large impact, a very large connection to CVI. And we just have to really make sure that they're measuring that our children are being able to access and measured accordingly. Mary spoke about the domains that we're looking at with the DEE-P4. And if we think about those domains, we think about motor, our children are not going to move toward or reach for something that they don't know is there. If they don't know it's there, if they don't know what it is, how can we expect them to move toward it? For the social domain, our children with CVI have such a hard time looking at people's faces. And if we can't look at their face, number one, we can't take social cues from their facial expressions, but others assume because they're not making eye contact or looking towards your face that they're not engaged or they're not interested. And so many times that is not the case. They are physically unable to look at us. And so they're missing out in that engagement, and they're missing out on the social cues. When we think about cognition, the domain of cognition, if our students can't access visually what we're showing them, how can we expect them to learn? How can we expect them to make a choice if they can't visually interpret the targets that we're presenting to them? If we think about communication for our kids who are nonverbal, and we're showing them these pictures or these those egghead things, right? We have the egghead that's yes or no. Our kids cannot visually, our kids with the greatest impairment cannot visually interpret that. And so instead of saying this tool is wrong to help them communicate, that's the case. We are blaming it on the child's inability to move forward in their communication, when in reality, we just aren't giving them the tools that allow them to show us how they communicate. And when Natasha was talking about awareness, right, our students, our kids with CVI, so often when the environment or the target is so overwhelming, they shut down or they melt down. Those are the two things that happen when our kids are overwhelmed. So again, we're blaming the child's behavior on their inability to participate or access, but in reality, we're not giving it to them in a way that makes sense to their vision. So, yes.
Thanks, Becky. And in terms of what we're doing here, you have been leading with a lot of help from Natasha and other team members, a novel tool, right? So I think that's pretty exciting too.
Yes. So we are working towards the framework that we're working from is through Dr. Christine Roman Lancey, and she is really the leader in how we look at CVI. And so from that, we've developed a parent tool that that we're trialing to see if the answers we receive from the parents match what we see assessment wise, and can we put those two things together? And if we have a reliable tool that allows us to gain that information from the parents, then we have a jumping off point on how we can then modify the materials for assessment.
Mm-hmm. And we know CVI is massively underdiagnosed. So yeah, it's good for everyone to take note of this and think about it in their communities. And so thank you so much, Becky. Okay, where we're headed. Jenny.
Thanks, Gabby. This comes back to me. So we have this massive data and very valuable data, and it is our commitment to be able to finish our projects across all of the domains that we've been talking about today, and see where they take us, where we in terms of being clear on what measurements will work best for these children. So the DP4, Mary is leading that work and is writing up a manuscript, which is describing the scores that we measured with the group, the rash analysis, which gives us even more insights into how those different scales within the DP4 are functioning. And because you remember, she mentioned there were gaps in difficulty. So there'd be some items and then there'd be a big gap until there were sort of more items in. And so that means that the levels of difficulty are not being measured in a systematic, small, stepwise way. And because of that, those patterns were just a little bit different across each of the domains. And we have the idea that potentially we could consider an alternative scoring method for the DP4, and we've done some preliminary work looking at that in how we can have a pan developmental score and combine particular items across the domains into the one sort of a subscore of the DP4, and we're quite excited about that. It's looking quite promising, and we really need to do more thinking and more consulting and some more analysis to be clear on whether or not that will be of value or not. So the work will show us that there is value to the DP4, and we need to publish that, and there could be an improvement that we can take from our findings and then present that as well. With meaningful change, that's heading towards a manuscript very soon, and the possibility of developing a meaningful change tool is in our minds. And we like that idea because it could go into a potentially we have a vision that it could be used in clinical trials, even if there wasn't measures for every single one of the domains, which often isn't the case, but there could be core developmental change that could be important. And this could be an efficient way to include an extra measure within a battery of measures for a clinical trial, and could be very important for clinical practice. So we're determined to pursue that idea. And as you heard from Natasha on awareness and Becky on CVI, there's ongoing analyses with the data that we have. And for example, the awareness, Natasha alluded to this really rich set of ideas that are in that concept. And we want to map that more clearly so that we can then measure more clearly. If we have a map, and that's what she's doing now, when we know how to measure it. And the same with CVI. We had those questions in our survey that many of you will have done that were based on the clinician assessment that Becky described, and how can we use some parent report data to distill that into a very simple tool that could give an indication of the child's CVI. Those are our ongoing tasks. So at the same time, we are thinking of a new project, and this relates to communication. It was the most frequently prioritised domain in our data set, and we know that for other groups as well. For example, Angelman, Rett syndrome, CDKL5, there's lots of other conditions where the communication has been called out as a priority. But our data is particularly important because we are not just one condition. We are lots of different conditions, and we therefore have a much more diagnostic scope, and we can therefore speak for a wider group of communities and children. So it really is a call to action. And then it says, well, how do we measure this most important domain? So we know, we have some knowledge, we know there is some explanation of communication for individuals with severe developmental impairments. That's limited. There is some, but we could potentially build that up. And we know also from what we saw with the earlier data from Mary that scores are very low for the DP4 in the very impaired children. And we know also from previous work with Anberg's assessment of communication with the Vineland in her SCN2A study, that there's often very low scores, and we don't necessarily have the granularity. So that brings us to using our call to action, using our knowledge, and entering a discovery phase and asking the question, how do we conceptualize communication in severely impaired individuals? And then if we have a clear map, like Natasha is doing with awareness, then we can say, are the measures that we have fit? And then what needs to be done if there need to be adjustments and so forth. So that is, next slide. So we'll just sort of give you a brief preliminary sketch for our ideas in terms of communication. And our aim is to develop a conceptual model for communication, and our methods would use iterative and very comprehensive consultation with stakeholders. Now that's parents, that's community groups, that's professionals, healthcare professionals, and so forth, and industry as well. And then when we have a conceptual model, we would evaluate how it is covered by available measures, and there are measures also in development as well. So we would use all of those measures. So the questions are, what does communication look like if impairments are severe? And this is really being a journalist. It's how, where, why, what, who. It's exactly that. So how communication happens and what, why does it happen, and when, where, and with whom. So we're very investigative journalists in that regard. And then we have to realize that there are factors that impact the communication, and this connects with what Natasha was explaining earlier with awareness. And just like awareness and responsivity might be impacted by other things, communication is very much impacted by other factors. So those factors might be internal to the child, their musculoskeletal functioning, or their vision, cognition, awareness, and also the presence of pain. And then there's factors in the environment. There's the noise in the environment, the setting the child is in, their meds for seizures, their other meds, and the role of the communication partner. So there's a lot of drawing together of information that we want to do to really build this comprehensive model. And so that will give us a benchmark for how to check other measures. And then we also will understand the determinants of communication abilities, and that could point us to testing of interventions to reduce determinants that are modifiable, and also could give us insight into how that a measure of communication could be more widely used in clinical trials, even if the primary aim of the clinical trial is not simply about communication, it's about other things, but because it is so connected with other domains, we may be able to advocate for that. So that's sort of ideas that we're working on. And I think that's my summary, Gabby, of where we are.
Yeah, thanks so
heading.
much, Jenny, and everyone else. I think we'll take a pause here and take some questions. We got a great one, which is, will publications from the Parents Speak survey always be framed in the context of being DEE conditions, or more broadly as severely impaired individuals with NDDs, as this likely has utility well beyond just DEEs? And I wrote in the chat, this is something we've been talking about a lot lately. So does somebody want to start us off with some of our latest thinking around this? Mary, you look excited. Or Jenny? Yeah, go ahead.
I could start, but I know Mary and Natasha need to contribute as well. And we agree with that point, because the children, as we have in our sample, we have about 80% parents reported a genetic cause for the child's condition. So 80%. And then we know some of those children may have a genetic cause that has not been identified. But some of those children, there may not be a genetic cause, and they may well fall into a wider group of children who have severe to profound impairments. And I think our work does translate, because we are crossing so many conditions, genetic and some not genetically caused DEEs, so that we actually have data that represents a very wide group of children. So my feeling is that we do, we will be able to generalize across to any child who shares severe developmental impairments. And I think Natasha and Mary might.
Yes. Short answer is yes. I agree. Yeah, I think with our sample, there were, because we really focused on recruiting kids based on their functioning level, and we were really specifically focused on non-seizure outcomes, there were kids in the sample who didn't have epilepsy, but are functioning, in the severe to profound range of impairment. And so these kids, are similar in a lot of ways, even though they don't have seizures, at least in terms of their functioning level. And as we're really focusing on creating a measure that can be applicable to lots of kids, as Jenny mentioned, transdiagnostic, we're not focusing on one specific genetic disorder. We really want to make sure that we're understanding functioning level as opposed to like genetic disorder. And not that genetic disorder cause isn't important. It's important in a lot of ways, especially when you're thinking about, precision medicine or gene therapy. But in terms of functioning level, we think there's a lot of similarity. And so that we can use one tool across lots of different groups. I think the other part is that, if we're thinking about precision medicine, a lot of times what we're looking for is a change in things other than seizures, right? So if there are kids who don't necessarily have seizures, we want them to be able to have their skills measured and potentially be part of a therapy that may impact their genetic condition. And if you have to have seizures to benefit from that treatment or participate in that clinical trial, then some kids are going to get missed. So I think yes is the short answer. We really hope this will be applicable to NDDs more broadly than just DEEs.
And we have the vision that this is going to be even broader than that as well, right? Like we presented this concept and these ideas at other meetings, and groups like ALS and other neurodegenerative disorders see utility for tools and have gaps as well. So while our mission is not to validate for those groups right now, we're starting here, I think, and all the others can weigh in if I'm saying anything incorrect here. But yeah, so I think that this is work that needs to be done on a much broader scale, and we're starting where we are here, and then hopefully it can be taken broader. And I welcome other people to drop questions or comments or thoughts in the chat. But I think, while I think we'll give it a few minutes so people can drop ideas in there or thoughts or, something that resonates for you. But I thought maybe I would throw something out there for the team as well, which is, we're taking on something here that, when we started pitching this project, a lot of people said, oh gosh, somebody should have done a long time ago. We need this. This is so important. What makes this particularly relevant right now, for this work to be happening? And I see a question come in, so maybe we'll, we're at a time where there's more gene therapies, N of ones, all those kinds of things happening. So does anybody want to talk about why this feels like an important time for this work? Or I can answer my own question too. Yeah. Well, also, I mean, what I can say from a personal perspective is that as the mom of a child who's very profoundly impacted with a disorder, I've seen clinical trials that are emerging and have one trials that are coming out. And I was really scared that there wouldn't be a place for kids like Elliot in these trials, and that there would be questions left unanswered about the ability of these treatments to really help people with not just seizures, which is, as we all know, is always the primary endpoint in trials for these seizure disorders, but for what really matters most to us, right? I would take a drug that helped Elliot be more alert and awake and increase his cognition in a minute. But if there aren't ways for us to be able to prove that there is improvement in those areas, then we've seen it in the past that those drugs, those treatments don't get to market because there's no evidence, there's no proof. And so we're on the horizon of some really powerful treatments, but unless we can prove that, they can be efficacious, then they'll be disappearing. So Heidi says that similar disease trajectories will be useful. The difference in response over time based on seizures, age, sex, mutation type will need to be considered to stratify patients and inform clinical trial design.
Do you want me to
Yeah, we know. Yeah,
Heidi,
thanks, Heidi.
Heidi, that's so important. And I think that raises a limitation of our work at the moment. We are cross-sectional, and cross-sectional gives us a snapshot, but doesn't necessarily tell us what's going to happen next. And so those points are really important. So there are studies in but with other groups where, for example, the CDKL5 study that's now collecting longitudinal data, so they can look at who is improving, who is not improving, who is just staying the same, who is declining, and then can look at who those children are and which characteristics there are. So there's lots of factors that we can't do with a cross-sectional data set, but that speaks to the possibility of potentially planning for that in the future. I think longitudinal data is important. One thing we have talked about, what we can do is the best we can do with the data that we have, and that's our task at the moment. And what we have talked about is how we can actually do this in a way that would be efficient, collect longitudinal data, and we do talk with anyone who will talk to us about potentially using the work we have done in their clinical trials or in their therapy interventions, so that we can find a way to understand responsiveness for particular individuals and at least partly address that really, really complex question. So thank you.
I think that's one of the stages. Go ahead, Jada. Yeah. You're muted, though. You're muted.
I had a question of folks at the end. We were going to try to summarize how different people can be involved, and particularly how the work ahead will really need continued engagement by families and patient groups. I think all of you mentioned that, and I wondered if you might give a little bit more ideas about Mary, Natasha, Jenny twice, both on the meaningful change and the new communication concept. All of these are going to need more input from families, and whether it's focus groups or assessing new instruments or new concepts. So rather than my just summarizing at the end, there's need, maybe we can give a little bit of a flavor of the types of ways we may be needing more family input to really move forward. Jenny, I think you covered it in both the areas of meaningful change, needing more family input in the concept, and then in the communications work. Can you give a flavor of how we might be reaching out?
I can. I mean, in terms of meaningful change, we have to finalize our paper. That is number one, because then we have the support of it being peer reviewed, and that is a step in science and progress that we have to be sort of have it in the public domain, and people who are qualified have reviewed it and said this looks fine, and if there's problems we address those. So that's a part of the process, but that will hopefully not be too much longer, and our heads are actually ahead of that anyway. And so the idea of developing a meaningful change battery that is succinct across developmental domains is an exciting one for us. But is that excitement shared by anyone else? It's the in Australia we call it the pub test, and if that looks okay, right? So does it have face validity to anyone else? And importantly, I think if we were to develop something, what the best way for us to do it would be to use co-design methods, and that means we would have a small group of interested parties, and that could be some parents, that could be somebody from, with more of an advocacy role, and potentially any end user, even industry could have a place at this table to then co-design and help us take it through iterations with, I've done that before with other things, but I think for this, because it's for resources, actually, not for developing a measure, but for this one, because it's so close to the heart in terms of meaningful change, I think co-design could be really well suited to that process. And so I guess hearing your thoughts on, does the idea sound good or not? And Frank, responses are perfect. And then the second thing is the idea of co-design as a way of being iterative and responsive to multiple needs, so that we can kind of put this idea down on paper and make it something really, really tangible and useful. So I guess they're my two questions for you in relation to meaningful change. The same questions apply to the concept of interest being communication, and potentially that would involve parents. It would involve speech therapists. It would involve a range of stakeholders to make that comprehensive. The goal is to make a map, and that is less about co-design. It's about coalescing, bringing together available points of view and knowledge that we have into the one map. And so that's a slightly different output. So I guess but involvement is critical to both of them. They're half the value if there's not authentic and proper consumer involvement and contributions.
Gabi, I have a question for you. We do a lot of work trying to build partnerships with different pharma companies, biotech companies, and a number of them are interested in where we are and how to get involved. And I know this is a good forum of good opportunity for us to have these companies get a feel for the work we're doing. But I wonder if you could summarize how industry partners are involved, how we work with them, and how they can learn more and get involved.
Yeah, so I mean, maybe I'll start by summarizing all of the different partners that we have, because we have a steering committee which has patient advocacy leaders, most of whom are also parents, and caregivers of loved ones living with these disorders. Also on that are clinicians and researchers and professionals and therapists who work in this space to help guide the work that we do. And then we also have an industry advisory panel where we bring together companies who are all ranges of companies. Some have nothing to market, some are, big companies and have things in market and a large pipeline. But the idea is that we all come together for meetings and opportunities to discuss the work. We share what we're doing, what our plans are. We get feedback from people who have a lot of experience in clinical trial development, in drug development, in engaging with the FDA and regulators, and what it takes to put on a successful clinical trial and what you need to do. And they help us understand what they need from us to have tools that really work in the context of clinical trials, and help shape, what we're doing here in a way that ensures that what we're working on is, we're very grounded in patients and caregivers. So that's always going to be our immediate vision and guiding light. But we do need that insight. And we have some really incredible partners. We always welcome more because everybody brings a different perspective. And the industry partners also help fund the work that we do because this is clinical research. It does take money. So we always welcome people to reach out and ask questions and learn more. And, we give briefings and interact with companies to help them understand what we're doing. So I think there's lots of opportunities to get involved here, both as Jenny was talking about, as families and caregivers who can contribute, industry partners and biotech who are interested in contributing to this work and being a part of helping us push forward these tools that are going to be really critically important for everybody who's working in the DEE and, quite frankly, rare disease space where there are, profoundly impacted subpopulations. Critical to the work we have done to date has been our incredible patient advocacy group leaders and partners who have helped us, sharing the work that we do, advising us, keeping us really focused on what the communities need most and what is really important to them, and bringing them in to be, trusted part of the research happening in their communities. And we do our best to try to give back too, right? So the data, we made those dashboards. We have discussions with some groups about, things that are in progress for them, how we can help, what we can learn from the data that we've got. So, we really are, and we partner with lots of different, groups that are doing work in this space and try to learn from each other and not duplicate efforts, but support one another. Something we didn't talk about today was our partnership also with Ardea Outcomes, who, helped us trial goal attainment scaling, which is an individualized measure. It's not exactly clear where we're heading with that yet, but it is another amazing tool that's in the toolbox for people out there to use. And it's going to be really important to be thinking about individualized measures, which is benchmarking progress against oneself as opposed to, some other standard, which a lot of these assessment tools are using age-appropriate standards, which most of our kids don't line up with. So, we're trying to be really thoughtful about how we do this work. And I think we've assembled a team that is really connected in this space, that is having conversations, bringing in new voices, new ideas. And the year ahead is going to be really exciting with some new partnerships. And as you heard, what we're planning to do. So we hope that you'll stay engaged, that you'll stay connected, you'll reach out if you have questions or ideas. And yes, Natasha just reminded me, that's true. The goal attainment scaling paper is now live. It's in the chat. Oh, I'm going to put that in the, that's, let me see if it'll let me do it. Yes. So I did it to everyone. You gave, so now everyone can get that. Another great resource. This is again based on our 2A pilot, where we did an initial read on the use of Goldhamen scaling in this subpopulation. So lots of really exciting things happening here. I'll give a last shout out to the audience here with us. If they have any comments or questions or thoughts, want to share anything going on for them, coming up for them in this discussion. Again, we will be out there sharing some more probably towards the end of the year. You'll hear more from us as we get deeper into, as Jenny laid out, we're finishing up some projects and we're starting new ones. So there'll be new publications coming. Jenny's got her meaningful change papers you heard, and so there's a lot happening. There's going to be the DP4 paper. We're doing some more work on the CVI. So lots that we're doing to try to help move this conversation forward and change the conversation about what's really important. So I'll just pull up this last slide real quick, which lets people know how to reach me. I think I know everybody on this call and they know how to find me, but just in case somebody's watching and wants to know how to find us. As you may know, Inchstone Project is kind of a research project of our Deep Connections work, which is really focused on empowering and providing resources and support to caregivers who are caring for loved ones who have DEEs and these more profound challenges. So we welcome people reaching out about that as well. But we also want to, again, take this time to thank everybody who's played a role in helping us get where we are right now. A lot of people, when we started talking about this, says, you can't do that. What are you talking about? That's ridiculous, especially as a patient advocacy group. But this is a testament to what can happen when you have an incredible group of researchers who are dedicated to this work, to this community, to partnering, and making progress for this community. So I think that's what we've got here, is an incredible team of researchers who are really open and committed to this idea of doing this work together. And it's a powerful way to move things forward. And we're excited about the progress we've made and where we're headed. And as we said, please, reach out to any of us, if you know us, to learn more and be in touch. And we hope to hear from you all and share more in the coming months. So thanks
very much,
everybody for being with us today.
Thank you.
Take care.
Appreciate you coming and listening.